maybe we'll get started. So John's not here today, so he apologizes for his absence, but it's my pleasure to introduce Dr. Hall Chu, who is our speaker today, along with two of our star residents, Dr. Jenny Kwan and Dr. Jovi Wong. And Dr. Chu first did his engineering degree at the University of British Columbia, and then moved all the way across the country to do his medicine at Dalhousie University in Halifax, before joining the UofT ophthalmology residency program and completing a cornea fellowship at Wills Eye Hospital in Philadelphia. So after that, he was recruited back to the university and has been on staff at Sunnybrook ever since, where he is an avid teacher of the residents. He was a great mentor to me and many of my peers. Hall, it's a pleasure to have you here this morning. You're a friend to many of us, one of the nicest guys in the department, and I look forward to your talk this morning.
Thank you very much, Amandeep. It's and welcome. Thank you very much for having me here, and it's an honor to be giving grand rounds. It's been a long time since I've given grand rounds, I think, so should have a lot of fun. I'm trying to delay a little bit to get more people to join before we start. Anyways, thanks to Amandeep for running all these great rounds. I think it's been a real godsend having the boss Amandeep running everything ever since COVID started. He's been doing great. He's like better than who'd be the greatest Blue Jay of all time. It's hard to say now. It's like better than Joe Carter.
Now we know you're lying.
No. He's better than Joe Carter. He's amazing. And thanks, Sharif. And thanks, Alan, for all your support and everything throughout the years. For those of you who don't know, I did my very first corneal transplant with Alan Solomvik when I was a resident. He let me do a PKP triple in a patient at that time, right before I left for my fellowship. So I give him great props, and great teacher. Unfortunately, the transplant didn't last that long, I think, but it was. But just kidding. It was great. So, and today we have two interesting presentations. The first will be by Dr. Jenny Quinn, who's our PGY3 resident, and she's a fantastic resident, very kind individual, great speaker, and very sharp, also a former engineer. Also, we have our second speaker is in the two slot is Dr. Jovi Wong, a very accomplished individual from the University of British Columbia. And we've been fortunate to have her join us here in our residency program. She's fantastic. She's got some great research endeavors, and we're really looking forward to working with her over the next few years. But they both have very interesting cases. And as we go through the cases, they're fairly efficient cases. We went through them, so hopefully you'll keep your attention so no one will fall asleep at this early in the morning. Make sure you get your coffee, but I think everybody will be pretty excited to hear what we have to say. So first presentation, without further ado, we'll start with Jenny. If you want to start and share your screen, and we'll just go through the presentations, and we'll have some nice discussions afterwards or in between.
Okay, so
So the title of the first talk is Spontaneous Corneal Melts, and Jenny will here we go.
okay, so again, my name is Jenny. I'm one of the PGY3s, and I'll be presenting my grand rounds titled Spontaneous Corneal Melts. Thanks to Dr. Chu for his help on this presentation. So we'll start off with the first preliminary poll. For those in the audience who do perform cataract surgery, what is your practice preference for a topical NSAID use after the cataract surgery? Number 1, use it routinely for all patients. 2, only if the patient is at risk for CME. 3, only if the patient develops CME. Or 4, some sort of other regimen. Just give it a second for everyone to respond.
All right, Jenny, I'll end it there. You seem to have a bit of a split. I'll share the results with you.
Okay, so pretty even split actually. So just keep those percentages in mind as we go through. And so we'll start off with the first case. So we have a number of cases, so I'll just briefly summarize the pertinent points for each one. So case number 1 is a 70-year-old female who was referred for persistent epithelial defects in both eyes. So her story was a couple of months prior, earlier in the year, she had cataract surgery in both eyes and had postoperative standard sort of drops, Pred Forte, Zymar, and Acuvale. She had a history of remote blepharoplasties and also had significant dry eyes. So she was already on artificial tears and serum tears for that. So a couple of days after her cataract surgery, she was complaining about foreign body sensation and a bit of irritation. And a couple of weeks later was seen by the ophthalmologist. He had seen that she had bilateral entropions and these corneal abrasions. So he continued her on the drops and kept following her up, but these never improved. And she had these persistent epithelial defects for a while, at which point she was referred to Sunnybrook. At this time, she was still on her artificial tears and serum tears. She was on Flarex as well, an antibiotic as well. And when we had seen her, her vision was poor, especially in the right eye. There was no RAPD and her pressures are fine. And this isn't actually her photo, but on examination, she had decreased sensation in the right eye and a large epithelial defect with about 80% thinning of the cornea. In the left eye, there is decreased sensation in the lower third of the cornea and about 40% corneal thinning. So she was diagnosed with neurotrophic corneas and a corneal melts, worse on the right side. She was just managed sort of medically and conservatively. There was a tarsorrhaphy that was done for the right eye to help heal the epithelial defect. And she was continued on her antibiotic drops. The topical NSAID was stopped and she continued on her dry eye sort of regimen, and oral doxycycline and vitamin C were added for her. She was also tapered off her Flarex. Blood work was performed for her and she came back positive for rheumatoid factor. So she's also referred to rheumatology. Case number 2, we have a 77-year-old female who was referred for a corneal perforation in the left eye. So like the first patient, a couple months before she was seen, she had cataract surgery in both eyes and had the standard sort of post-op drops, antibiotic, a steroid, and an NSAID. And on examination, her vision was poor in both eyes. She was counting fingers in 4 feet and 2400. And on examination of the right eye, you can see that there's this haze centrally, and it was quite thin. The cornea had a neurotrophic appearance. And on the left eye, the AC was flat, and there was a central corneal perforation with the wound leaking centrally. So on the left side, that area was glued and BCL was placed. On the right side, there was a tarsorrhaphy done to prevent an impending perforation. So just following on with the left eye and how she was seen in follow-up, the next day she had to be re-glued because the glue had disappeared and the AC was flat again. And then if we see how she's done in follow-up, you can see afterwards there's still the glue centrally, and she starts to have neovascularization of the cornea. Here we can see that the glue has been removed and then there's this epithelial plug, but the cornea was still quite thin, especially centrally, and there's a lot of NV. And eventually this is what she looked like. A lot of corneal hazing and scarring, especially centrally, and there's still pretty prominent NV. During her visits, there was blood work that was sent off for her, and she also came back positive for a number of rheumatologic markers. Case number 3. We have a 74-year-old female who was referred for corneal thinning in the left eye. A couple of weeks prior, she had cataract surgery in that left eye, and again, had those standard 3 post-op drops. Also had a significant history of dry eyes like the first patient. So she was referred to Sunnybrook for this corneal thinning that just didn't improve, but she was asymptomatic at that time. So her vision was 2200 in both eyes. And when we looked at her, now this one isn't actually her photo, but in the left eye, there was significant corneal thinning intranasally and a small perforation. So she was managed with gluing to the area and Vigamox to that eye as well. And her Pred Forte and NSAID were stopped. Blood work for her was sent off, and she ended up having to be followed by rheumatology for positive rheumatologic markers. So this was in September, and then she was continually seen in follow-up. By the time she came back in January of the next year, however, again, this isn't her photo, the glue was still in place, but she had a 90% hypopyon and vitritis. There was a lot of corneal thinning, and a corneal scrape was done for her, which came back positive for strep anginosus. So she was started on fortified antibiotic drops. Eventually, though, she did need a PKP and vitrectomy, and she's continued to see it seen in follow-up. And the sutures continued to loosen and they had to be removed. And her cornea still continued to thin even with the PKP. Eventually she perforated again. And so at this point she had this blind, painful eye that was now physical. So in the end, an evisceration had to be done for her. Now we have our final case, another 77-year-old female, and she was referred to Sunnybrook for a corneal ulcer and endophthalmitis. So a month prior, she had cataract surgery like the other patients and was on the post-op drops. A couple of weeks after her cataract surgery, the ophthalmologist noted she had a corneal abrasion in the right eye, so just continued the antibiotics, but this never got better and it eventually evolved into a corneal ulcer. So sort of the kitchen sink was thrown at her at this point. She started on fortified drops, fluoroconazole, and oral acyclovir, but still continued to worsen and actually developed endophthalmitis. So by the time she was seen, her vision was LP in that right eye, and she had a right RAPD. And you can see how she looked when we saw her. A lot of injection in that right eye and a complete hypopyon. There is this corneal melting and impending perforation, but actually at this point she was side-L negative. In the left eye, she had severe dry eye with filamentary keratitis. And on B scan of that right eye, it showed vitritis as well. So the management options were discussed with her, including just conservative management, doing a PKP, or going straight to evisceration / enucleation. She actually opted for the conservative management. So the fortified drops were continued and oral moxifloxacin, doxycycline, and vitamin C were also added for her. So she was seen pretty closely in follow-up. And one day she came in, she was quite happy because she felt like her vision had improved and maybe there was a bit less pain. But when we took a look, we can see that there's no more hypopyon, but there's this uveal prolapse with the iris tamponading the wound. So still at this point, she was side-L negative. And again, we rediscussed the management options for her, and she still wanted to be managed conservatively. So you can see it as the eye develops, there's still like a lot of concern regarding the status of the eye. So eventually she, like the previous case, also needed an evisceration. And during her follow-ups, blood work was done for her. She came back positive for rheumatoid factor and anti-Ro. So she, like the other patients, was referred to rheumatology. So if we look at all of these cases and we just think about what they have in common, as I mentioned, blood work was sent off for a number of them for a specific purpose, and they all came back positive for some sort of rheumatologic marker and are continued to be seen by rheumatology. All of them had cataract surgery, some of them a couple of weeks before, some of them a couple of months before, and all of them were on some sort of topical NSAID. So let's focus a little bit more on this topical NSAID use and shift gears into the second part of the talk, which is looking at NSAID-induced corneal melting. I won't go through the exact details of the slide, but if people remember from medical school, NSAIDs are COX inhibitors, and in the eye, this helps to control ocular inflammation. There's only a couple of approved indications for topical NSAIDs actually, and it's for pain and inflammation after cataract surgery and ocular trauma. But we often use them off-label for things like CME, which can happen after cataract surgery. And there was a Cochrane review that looked at the efficacy of NSAIDs versus steroids versus NSAID plus steroids for CME. In the end, it wasn't really conclusive, but they said maybe the NSAIDs might be a bit more efficacious. Sometimes they are used for pain after corneal abrasions. And there was a Cochrane review that looked at this as well. And they concluded there wasn't any strong evidence to support topical NSAID use for traumatic corneal abrasions. We do tell patients about the side effects of NSAIDs, common things like stinging, burning, red eyes, corneal anesthesia, which is why it is effective for pain management. Uncommonly, some patients can get contact dermatitis. And importantly, there can be corneal complications as well. Things from like SPK to corneal infiltrates, epithelial defects, and importantly, corneal melts. So what is this association between NSAIDs and corneal melts? Well, in 1999, there was a survey that was put out to ASCRS members, and that was the first time where this issue of possible corneal melts associated with NSAIDs was first brought up. In 2000, there was a paper looking at a couple of patients who presented like this. 2001, a couple more papers. And since then, there have been numerous case reports and case series that have reported patients who have experienced corneal melts and perforations after using topical NSAIDs. So based on this information, what do we know? Well, the papers that have come out have pretty small sample sizes, so it's hard to pinpoint the exact incidence, but it's most likely fairly low and probably pretty uncommon. In terms of onset, it's variable. So some patients present with corneal melting a couple of days after using NSAID, others present much later. There's one report that said a patient presented 17 months after with the corneal melt after using NSAID. And in terms of dose and duration of treatment, it's unclear how it affects risk because of the small sample sizes, but if we think about it logically, it's likely to be significant. In terms of the underlying mechanism, there's no clear-cut mechanism. It's likely multifactorial, and there have been many hypotheses that have been postulated. Based on the mechanism of action of NSAIDs, it also causes an increase in MMP levels, and this is thought to induce corneal melting. There also could be other factors like white blood cell infiltration into the cornea or decreased corneal sensitivity. So again, it's likely a multifactorial mechanism. What is pretty clear is that often these patients have an additional underlying trigger. So local ocular surface disease that cause corneal compromise like dry eye or keratoconus, or an ocular surgery that compromises the surface can be a trigger. Systemic conditions like diabetes can be a trigger as well because of nerve damage or neurotrophic corneas or delayed wound healing. And also this can cause increased MMP levels in and of itself. Often these patients have some sort of underlying autoimmune conditions like rheumatoid arthritis or Sjogren's or rosacea. And corneal melting may actually be the initial presenting symptom or a presenting factor for patients that have primary Sjogren's syndrome. So again, if we revisit our cases, we know all of these 4 patients were on a topical NSAID, and we can see that they had additional risk factors that served as these triggers. All of them had cataract surgery, which can compromise the surface. A couple of them also had dry eye, and all of them came back positive for some sort of rheumatologic disease. In fact, 3 of them were diagnosed with Sjogren's after first presenting with this corneal melting. And if we look at how these patients turned out, patient number 1, who was managed conservatively, ended up with poor vision, especially in that right eye that had the worst corneal melt. Patient 2 had poor vision as well, who was managed conservatively. Patient 3 had to have an evisceration, and patient 4 also had to have an evisceration. So you can see it's quite a poor outcome for patients who have these corneal melts after NSAID use. And so that's why we need to keep this in mind, because we need to mitigate the risk. If we're thinking of prescribing NSAIDs, we need to balance the risk versus the benefits and individualize them to each patient, thinking about each of their risk factors. And if we do need to put the patients on NSAIDs, then we should restrict the frequency and duration of use to the minimum required. Of course, we need to monitor them closely if they're on the NSAIDs. And if at any point there's any hint of corneal compromise or corneal melting, then we need to stop the NSAID immediately and start the appropriate treatment for them. So that's the end of the presentation, and we'll just revisit that first poll. For those in the audience who do cataract surgery, what is your practice preference going forward? You'll use it routinely for all patients. Number 2, only if the patient is at risk for CME. 3, if the patient develops CME. 4, an additional option to reconsider its use if they have severe dry eye and consider a room workup if needed. Or 5, some sort of other regimen.
Wow, Jenny, thank you for that talk. That was quite enlightening and scary, perhaps. We'll let the poll run for a couple more seconds, but the early results do seem to indicate you've made some change in practice patterns this morning. So I'll show you the results here.
Okay, so there's a good amount of people that opted for number 4, which is great. And there's just one last poll here, just a brief summary. For those who routinely use the NSAIDs, or similar to the previous poll, but do you think that you'll change your NSAID use after cataract surgery? Yes or no?
Jenny, while we're waiting for the poll to go, that's great. Thank you. Thank you very much, Jenny. That was an excellent presentation. And for a lot of you guys out there doing presentations, stuff like Jenny and Joby both put a lot of effort into it, especially the past few weeks. And I think all Thanksgiving was spent on that, including last few days. So thank you very much. It was well put together and great presentation. And it's nice to show that people are thinking about it now. I mean, I use topical NSAIDs also for patients, but I use it with great discretion. I'm sure probably Alan and David do, especially too, because I remember when I was a resident, David, we had a presentation, and I think David and Alan had a long case series. I think Dr. Singhal actually presented it, and what happened was, I remember David saying that he's seen more corneal melts than he's actually seen of CME. And present as corneal specialists. So we kind of are biased that way. We do see those cases more often than not. But having said that, there are indications where topical NSAIDs are required. Typically, I use it when patients have pre-existing DME or CME or have a ERM present. But I also will evaluate them to make sure they don't have any severe dry eye issues. If anyone has any rheumatologic issues, for sure, I would not recommend using topical NSAIDs at that time. You may, even if you're concerned, you may want to consider intravitreal injections, which is much safer. So, Alan, do you have any thoughts on that yourself? I know you like. Nice to hear your viewpoint, and maybe we'll ask Sharif for his viewpoint also, and Amandeep for his viewpoint. If there's any questions, we can answer that too.
Do you have about an hour for comments? First of all, just starting from the beginning, spontaneous corneal melts. My understanding of spontaneous is that there's no underlying cause. And I think, Jen, first of all, wonderful presentations, great collection of cases, beautifully presented, clearly presented. So these are not spontaneous. If you scratch a little bit under the surface, there's always a cause. Number two, we found this, going back to what Hall was talking about, our original discussion with Neera, David, both the generic and the trade NSAIDs. At one point, they were just saying it was the generic NSAIDs. We've seen melts in both trade and generic. Number three, I think we've done a really good job of stopping emergency docs from using steroids, but now they're using NSAIDs. It's the new steroid. And I think they're also using topical anesthetic for abrasion. And I think we really need, this has come up a few times, and we need to be really careful with this. As ophthalmologists, we know that this can result in corneal ulcers, corneal melts, corneal perforations. So I think we need to really try and bring home that idea that, these are not drops you can use indiscriminately. Hall, like you, I use an NSAID with all of my cataracts, unless they are dry eye, Sjogren's, some underlying reason why not to use them. But I think these are drops that you need to follow your patients, which we do with cataracts, and it's for a limited period of time. And I think they are effective, just talking with my experience, in reducing CME. And my last point is that there's more than one way to deal with the melt. And I'm presenting this at the Academy as a course that I'm a part of, where we did actually, in a rheumatoid melt, we did a phaco, IOL, and small little disc of a DSEC to plug the wound, which was plugged with iris. We left that to the end. We unplugged the iris from the wound and put a little DSEC patch inside. And the lady ended up with a sealed cornea and actually good vision down the road. So just think of that. It's not always available, but we know when we put on glue, it could last for many, many months. This was a nice approach because it allowed us not to have to put a histoacryl to seal the perforation, and it was a perforation larger than could have been sealed with just histoacryl. So I could go on, but I'll stop there.
Thanks, Alan. We'll save it for another Grand Rounds presentation. I hate to be controversial to Dr. Slomovic here, but I'll counter with this. I actually do not use any topical NSAIDs on any of my patients, except if they have previous history of CME or DME or ERM. So, I noticed I was quite shocked actually at the first slide there, where the majority of people actually do topical NSAIDs for all their patients. I know people don't want. I mean, it is a lot of chair time and a lot of issues discussing the patients post-phaco if they do develop CME, and most people are expecting these miraculous outcomes because the expectations are so high now with cataract surgery. And if you get a few patients who get CME, then it's quite a, almost like a disaster for them. But really, I think if you look at on the flip side, if a patient ends up like one of these 4 patients we had who otherwise had routine cataract surgery, really had no issues, and they didn't have the NSAIDs, there was a good chance that they probably would have done very well instead of being 20/80 at the best or being monocular and having just one eye. Anyways, that's my only time I'll ever argue against Alan. I only have a few more minutes before we get to our next case, but Amandeep and Sharif, do you guys have anything you'd like to mention?
Well, I got to say, again, Jenny, that was an excellent presentation. I think it really highlights when not to use topical NSAIDs. Clearly, if there's severe dry eye, if there's rheumatological disease, if there's localized corneal problems, epithelial defects, we should not be using it. But like Alan, Hall, I use NSAIDs routinely otherwise. And in patients, we know that post-cataract surgery, all patients develop CME. Fortunately, the majority are subclinical CME, and this is an effective way to minimize that and hasten the recovery of the macula. So I think we have to be diligent in ensuring that we choose the right patients or the patients we shouldn't be using it in. But I wonder if it is okay to use it in patients that don't have those risk factors.
And I think what Jenny's research on the Cochrane database, there's really no strong evidence, I think, to support it. I mean, it's similar to a question of how many people give pre-op antibiotics a week before surgery. I think that's one of the biggest shams around. I mean, even putting an antibiotic drop in right before you do cataract surgery, like at the day of, I mean, it's useless. Aren't you going to use the povidone iodine to kill everything on the eye? I think it makes, it's just basically selling more medications and also probably breeding more risk for resistance. That's what my thought is. But anyways, Amandeep gets the final word because he's the right the panel here.
I wish, man, I wish, but thank you. I do use NSAIDs pretty routinely, but this certainly gives me pause for concern. The interesting thing I thought was all 4 patients had a rheumatological diagnosis, but it was only made after the fact. So that doesn't even help us with the pre-op counseling and selection of the appropriate patients. So that's a little bit scary. There was also a female preponderance there, so I found that a little bit interesting as well. I do have a question for you, Hall and Alan and Sharif. Nancy Epstein asks a great question, which is, we're talking about patients who have dry eye as perhaps not being the best candidates, but that's a huge number of, or a huge percentage of the cataract population. So how do you decide who has sufficiently dry eyes to hold the NSAID?
Well, I mean, typically with these patients, and Alan can speak because he runs the largest children's clinic probably in Canada, is anybody's got filamentary keratitis, I think that's a given right there. Okay, something's going on there. Anybody who has severe dry eyes, I mean, I think you have to look at it and when you're doing biometry and things, if you have very irregular ocular surface, number one, your IOL calculations are going to be pretty all over the place. So, I think if you use that as a good gauge, you can probably decide that's one thing. But most people who have dry eyes and SPK, they can be treated and they can be fine. I think you have to there's no black and white answer here. I think you have to, judiciously use it. I think you have to think about it, maybe make patients aware that there is a risk for this. So they're aware of the risk of, you have CME or you have dry eye or corneal melt, it's rare. So again, these are rare conditions. So there's no black and white answer here. Yes, go ahead now.
I think I agree with you completely. And what I look for, if a patient is symptomatic with dry eye beforehand, I stain the cornea. And if you see a lot of SPK, I think even without filaments, because that's the next step. And certainly I will not treat those patients with filaments, but if they have a lot of SPK in the cornea, in the interpalpebral area, in the exposure area, I won't use an NSAID. The other thing, I tell all patients they may get more dry eye, especially if they have a dry eye pre-cataract surgery. After cataract surgery, I think they get more of a dry eye. And I tell them about that because patients come back And, you know, the old saying, if you told them beforehand, they own it. If you tell them afterwards, you caused it. So I think it's, I do tell them beforehand that they have it, you know, that they may get a dry eye afterwards. But I use SPK, and I think you should try to treat the SPK beforehand because it's really going to affect your biometry significantly. So we're just doing a study, we're finishing with Yellen about using some of the dry eye products. I don't want to mention any brands in particular at rounds, but to try to clear the SPK before going ahead with cataract surgery. And we have shown that the biometry was more accurate if you treat the dry eye before you go ahead with the surgery.
And on that final note, we have the final say from Dr. Solvik. Thank you. We're on to our next case. Thank you, Jenny. Thank you for the great feedback from everybody and all the great questions. Okay, next is Jovi Wong, PGY2 extraordinaire.
Thank you so much, and thank you for the opportunity to present grand rounds today. So today I have a case of non-responsive peripheral ulcerative keratitis. It's a single case that will start from beginning to end. We'll get right into it. Okay, so here we start with the initial referral back in May 2019. So we have an 83-year-old Caucasian male. He's referred by his optometrist for a right eye temporal conjunctival lesion. His symptoms are some glare and discomfort in the right eye, and his vision's 20/25. So initially by the optometrist, he started on a course of Pred Forte 4 times a day. It didn't really work, so we went up to Q3 hours and started diclofenac drops as well, which all provided a bit of symptomatic relief, but didn't resolve the lesion. So he has a little bit of past medical history and some medications, but they're not really contributory to this case. They're just here for completion. Then we have his first ophthalmology appointment with us. And as you can see, he has in the right eye temporal severe scleritis with scleral corneal melt, which is consistent with peripheral ulcerative keratitis, and the left eye is clear. So here we have some clinical photographs, and you can see temporally there's a scleral corneal melting here and some thinning. Under fluorescein, there's a little bit of pooling here. So we'll go straight to our first audience question. So in this initial management of severe scleritis and scleral melt, what would you do? We have 4 options. The first is to discontinue the topical NSAID and replace with an oral NSAID. We could start high-dose prednisone now. We could do a TB test first, and if negative, start high-dose prednisone, or else TB test first, and if negative, start low-dose prednisone. So just give everyone a minute.
All right, I'll share the results for you here. Bit of a split going on again.
Great. Okay, so yeah, we see a bit of a split. So in this case, what we did first was we started indomethacin, 25 milligrams 3 times a day, and Vigamox every 1 hour while awake to cover for infection. We did an urgent referral to rheumatology, and then we did the urgent TB skin test. We gave the patient a prescription for high-dose prednisone and asked the patient to switch from the NSAID to the high-dose prednisone once the TB skin test came back negative. We also initially did corneal cultures to rule out infection, and all of these came back negative. We'll just go through the differential for scleritis and scleral melt. So just to remember that up to 50% of these patients may have an underlying systemic condition, and this is typically an autoimmune connective tissue disease versus a vasculitis versus infection. And so the diseases listed here would be sort of top of the differential at first. We also have the very complete list here of all local and systemic diseases associated with peripheral ulcerative keratitis. As you can see, they are grouped into autoimmune diseases, infection, or other, but as you can see, the differential remains fairly wide, and there's still a lot of things to be thinking about in this initial presentation. So right away for this patient, given the severity of the sclerocorneal melt, we sent out a rheumatological workup ourselves and also sent the patient for an urgent rheumatology referral. All of these tests were sent out, Everything came back negative though, except for a chest x-ray, which had some bilateral opacity suspicious for interstitial lung disease. And so as a result, this patient is diagnosed with peripheral ulcerative keratitis and Morin's ulcer. And so for everyone, Morin's ulcer is a painful peripheral corneal ulceration with idiopathic etiology. There is a possibility that there's an underlying autoimmune process, but typically this is a diagnosis of exclusion where patients have a negative systemic autoimmune workup. There is a higher incidence in Africa, which is we wanted to note because this patient is Caucasian. Some risk factors include corneal surgery, previous trauma, and previous infection. And the differential includes Terrien's marginal degeneration and Pellucid marginal degeneration, among other things, which we'll go over as well. And just to note that the treatment includes topical immunosuppression. Topical steroids can be used as well, although there is debate in the literature about this because although it suppresses inflammation, it can inhibit healing. But this would be versus some oral treatment with oral immunosuppression versus conjunctival excision. And so just to note that the topical corticosteroids, although they suppress corneal inflammation, they're usually best avoided in cases of peripheral ulcerative keratitis because it can contribute to corneal melt by suppressing collagen production, and that the surgical conjunctival resection adjacent to the ulcer is performed to decrease the access of inflammatory cells and factors to the cornea, but it's still a bit controversial because it has not definitively been demonstrated to change the course of disease. Okay, and then, so here's the full differential for peripheral ulcerative keratitis. And so we have these listed as degenerations, infectious or inflammatory processes, and then local factors to the cornea. So again, a few things to still be thinking about in this case. So now we'll go over his clinical course over the next 4 to 15 months. So essentially the patient is diagnosed with idiopathic peripheral ulcerative keratitis, which has become corticosteroid dependent. Although he was initially managed with oral prednisone, the patient became symptomatic from the chronic high doses of prednisone. He became Cushingoid and quite uncomfortable. We tried Myfortic. We went up to cyclophosphamide, which comes with the risk of myelosuppression. So he had to be on weekly blood work to monitor for this. It didn't work, so his cyclophosphamide went up to a higher dose. That didn't work either, so we went back to Myfortic. We repeatedly tried to taper his prednisone, but this was unsuccessful, and he remained on high dose prednisone of 60 milligrams daily. We tried a right temporal conjunctival resection. Eventually, we had to switch to Humira, and we were able to taper prednisone. So now we have some clinical photographs. So you can see here at 15 months, his ulcer has significantly worsened. It's progressed centrally. There's thinning of the cornea further, causing opacification of the limbus. There's a central area of necrotization here with a leading edge, which is vascularized. At this point, the vision is 20/60, and remember, he presented with a vision of 20/25. And essentially, at this point, he's on Humira with a little bit of prednisone. We then move over to 20 months, and here the vision is 20/70. We see that there's progression that continues centrally and circumferentially, so it's starting to go around the cornea here. And this is often typical of peripheral ulcerative keratitis. It continues to be surface disease on this cobalt blue here. Now we move to 23 months, and unfortunately the vision continues to worsen. There's more pain despite the medications he's been on, and more thinning. So you can see the cornea is extremely thin here. The vision is now 20/25, and he has impending perforation, or sorry, 2200. So now we'll have another audience question, which would be, what would be your next step as the patient has impending perforation now? So there are 4 options. The first is an urgent corneal transplant. The second would be prophylactic glue with a bandage contact lens. Third would be an urgent referral to oculoplastics for evisceration or enucleation. And lastly, an amniotic membrane transplant. I'll give everyone a minute.
Okay, almost a 50-50 split here. I'll show you the results.
Okay, what an interesting result. So I guess we wanted to make the point that this is a discussion to be had with the patient, and in particular with our patient. Unfortunately, at this point, he had 90% corneal thinning with this impending perforation. He was very symptomatic. He still had pain. His vision was poor. He'd been on this course since the beginning. It's been 23 months of continued immunosuppression. And so he really did not wish to continue. And so he was referred to oculoplastics actually for consideration of evisceration or enucleation. And so a right evisceration plus the insertion of an implant and fornix reconstruction and tarsorrhaphy was performed, and this procedure was tolerated well. Just briefly go through the indications for evisceration. And so the indications would be endophthalmitis, penetrating ocular trauma, or a blind painful eye, which was the case for this patient. And notably, the contraindications would be any known or suspected intraocular malignancy, orthitis, and microphthalmia, which is relative there. We could discuss, evisceration versus enucleation for this patient, and in particular, the advantages of evisceration include a shorter operation, which is less painful, less disruption to the orbital tissues surrounding, and better cosmesis and motility at the end. And again, disadvantages include possible dissemination of intraocular malignancy if that's known, and increased risk of sympathetic ophthalmia compared to enucleation. So now I want to show you the pathology. And so here we have 3 photographs of H&E stained slides of the anterior segment. We have the cornea, anterior segment, and lens here. And so we wanted to point out that, so this is the area of pathology. You can see the cornea here. There's a step down to the area of very thin cornea. So interestingly, we were surprised to see that in the pathology, there's this infiltration of blue cells, blue nuclei, which is suspicious for squamous cell carcinoma.
Wow.
And on these pathology slides, we can look here. So here's another area of infiltration of the blue tumor cells here. On higher magnification, you can see that there's infiltration into the stroma of the cornea. This is another area of invasive squamous cell carcinoma. And perhaps best seen on the slide. So you can see here the step of the cornea, like where it steps down and becomes very thin. This entire area here is infiltration of tumor cells. And this entire piece here is a piece of invasive squamous cell carcinoma. So essentially at 26 months, we have this unexpected diagnosis from pathology of squamous cell carcinoma, both invasive and in situ. It was so unexpected that we actually asked for a second pathologist opinion, which confirmed the diagnosis of squamous cell. We found evidence of squamous cell carcinoma in multiple samples, so including in pieces that contain the conjunctiva, the cornea, the sclera, and focally on the iris and ciliary body. And unfortunately, because an evisceration was performed, we're not able to determine the surgical margins. And so the patient was urgently referred to radiation oncology. So a brief, literature review on peripheral ulcerative keratitis, which turns out to be malignancy, shows that this is very rare. We could only find 3 sort of case reports / case series, and this totals 5 patients overall in these 3 reports. And in all of these cases, all the patients presented with either peripheral ulcerative keratitis or some sort of anterior nodular scleritis. In all of them, there was no systemic cause that was found. In all of these patients, their presentation was resistant to treatment, and so they did not get any better. And so eventually this led to a biopsy, and the biopsy showed some sort of malignancy. And so in some cases, it was squamous cell carcinoma, but also other malignancies like chronic myelogenous leukemia, sebaceous cell carcinoma, and ocular surface squamous neoplasia. And in 4 out of 5 of these cases, eventually the patient unfortunately had to undergo enucleation plus or minus exenteration of the affected eye and organ. So we go towards the end of our case here where the patient undergoes a radiation oncology in-person assessment. And of course, keeping in mind this is during the COVID pandemic. The main concern here is that we have an unknown extent of the disease and there's possible spillage or contamination of squamous cell carcinoma into the orbit. Fortunately, clinically, he has no skin lesions, no lymphadenopathy, and fortunately now he's no longer in any pain. He undergoes staging with CT head and orbits, and there's no lymphadenopathy. His prosthesis is in place. We then consider exenteration versus post-op radiotherapy or adjuvant radiation therapy. And in the end, he pursues adjuvant radiation to the right orbit and has good effect aside from some erythema and dry skin as a result. We wanted to go through some take-home points. So altogether from this case, we learned that urgent referral to rheumatology is indicated in cases of scleral melt and thinning in order to rule out systemic conditions. And this urgent referral is important for putting the patient on the right track. Notably, prolonged systemic steroids can cause severe side effects that affect quality of life. This patient became very Cushingoid, and this was already apparent 4 months into steroid therapy, and he remained on steroids for almost 2 years. In particular, in this case, where pathology returns an unexpected result, which could significantly change the patient's clinical treatment, a second opinion may be warranted. In this case, we sought a second opinion because once we are considering malignancy as part of the differential, the patient will have to go down this road of treating their malignancy. So it's important to confirm. And of course, in this particular case where we have a suspected inflammatory lesion, but it's extremely resistant to treatment, this should cause us to consider alternative etiologies. And although it's very rare, malignancy should be included in the differential for peripheral ulcerative keratitis. And of course, if there was any suspicion of malignancy, then we would not have performed an evisceration. Instead, an enucleation would have performed if we thought the malignancy was localized to the globe, or else we would perform exenteration or consider radiotherapy as a primary modality, depending on the malignancy, if that was initially what we were thinking. And finally, Dr. Najawan wanted us to mention that if you remove something, it should be sent to pathology, and malignant specimens can appear benign on gross inspection. So it's important to send them. Thank you so much for listening to this presentation. And thank you so much to Dr. Chu, Dr. Usel, Dr. Haworth, and Dr. Najawan for their contributions to this case.
Thank you very much, Jovi. That was a great presentation. And again, much like Jenny, Jovi spent a lot of her vacation time working on this presentation. I really appreciate she really put together a great presentation. So thank you. Applause. Anyways, so PUK is a very difficult condition, and we see it as corneal specialists. We see a fair bit of it. And I've had a few cases where they've been resilient towards any treatment, and patients cannot withstand the systemic side effects that they had, and they do move on. And this was quite shocking when I received it, and actually took some time to get the pathology results. I'm actually joined here by Dr. Jeff Hurwitz, which is amazing. Good timing here. He's here for her next presentation later today for the residents, so it's nice to have the viewpoints there. But I guess I'll start with Alan. Have you ever had a case like this? And please unmute yourself before you.
The most famous words over the last 18 months is you're on mute. Yeah, great case, Jovi, really nicely presented. Hall, no, I've never had a case like this, but it really speaks to the point that maybe you want to do a biopsy before you go ahead. I mean, you did the right maneuvers. It was beautifully done and beautifully taken care of, but a biopsy maybe in a case like this, it'll make me think about this in future. It's in the differential, but you just don't think it, especially when they're responding to oral steroids. They're walking the walk and they're talking the talk. You think it's a regular case of PUK, but it's not. So one of the take-home messages I'm getting here is maybe do a little biopsy, and if any pathologists are on the Zoom, maybe they can comment on how much tissue they actually need to have made this diagnosis. Again, nicely presented, Jovi and Hall, great management.
Yeah, it was, it's quite, it's a terrible time anytime you have to remove an eye, but usually it's done for, the right reasons, such as a blind, painful eye, which is we're getting this point, and the fact that the patient could not tolerate it. I think it was, excellent points there, and things to think about, whenever we send people for eviscerations. I mean, it was a classic PUK Moran's ulcer. It did not look at all like an ocular surface squamous neoplasia, which I've seen many of, and I treat many of them. And it looked like, the perfect, PUK Moran's ulcer. So it just goes to show that, especially the last two valid points that Nav had mentioned there in the take-home points. So I don't know if there's any other questions there. Maybe, Jeff kind of walked into it halfway here, the Jeff Hurwitz here, but I don't know, how hard is it to get, you really can't get margins when you do an evisceration, correct?
No, that's right. That's right. But I think in response to Alan's question, how much tissue do you need? It depends what the ultimate result is going to be. I think with the squamous CA, you really need very, very little tissue. Just a little scraping can do that. And we oftentimes will just scrape the lid margin of a lesion that we think might be malignant, and very, very little cells you need. And I don't think it's all that disruptive. So, I think the point is that the last take-home point here was if you take tissue, you even though it looks completely benign, you have to send it to pathology.
Yeah, and thankfully, we do that for all our eviscerations and enucleations that are done, and also I think for people who are doing pterygium surgery, I think it's very important that you do send your pterygia for pathology. Alan had a paper few years ago, I think, about how many, how often do pterygia surgery samples sent to pathology, how often are they actually ocular surface squamous neoplasias or something that could be, a pre-existing condition that could worsen and become a carcinoma. So just be aware that whenever we're removing anything from somebody's body, their eyes, wherever, the cornea transplants, when we're doing the host cornea, we should always send these tissues off for pathology for analysis. And sometimes you get surprised, and that was the other point too, is I've had a case where we had someone who had perforated eye, and we removed some of the uvea that was exposed and did a lamellar keratoplasty, sent it off to pathology. It came back as a malignant melanoma, which was like, wow, but again, not clinically in keeping with what we were seeing there. We then resent to another pathologist for analysis, a reanalysis, and it was actually diagnosed as melanocytosis. So that, in fact, saved this poor young guy the need for basically an exenteration and radiation therapy. This is again a different case, not the one we're talking about today. So you have to have your kind of antenna up about these things when something's not clinically relevant, or in cases like this, just to be hyper aware. It's something, still I'm very shocked about this whole case here. So, but anyways, I don't think there's any other questions, are there? And I think we should all get ready. It's now 8:26. Thank you, Mino, for the nice words there. And I know I'll leave it up to Amandeep to close up the rounds. And thank you to Jenny, Jovi, Alan, Sharif, and of course, Jeff Hurwitz for being here. Back to you, Amandeep.
Actually, before we sign off, I have a question for Dr. Hurwitz, who's got a wealth of experience. Have you seen many cases like that where you have very low suspicion prior to an evisceration and then you come back with a surprise malignancy like that? That's shocking to me.
Yeah, I actually can't think of one. Eviscerations are generally speaking, from an ocularis point of view, preferable to enucleation in the cosmesis after and motility and that. But I think if there's any suspicion, you're probably better to do an enucleation rather than evisceration. No, I don't think I've seen this in an evisceration per se.
No, I'm not. Myrna has a question.
Yeah, this is something you read about in textbooks, but I'm surprised to see a real life example. So Hall and Jovi, thank you for enlightening us this morning. I think that was just a fascinating case. And Jenny, thank you for your series. You've given all the cataract surgeons in the crowd food for thought this morning. With that, we will end the round a couple minutes early. Everyone get on with their Fridays. Next week, we have rounds with Dr. Panos Christakis on uveitis. So we'll see you then. Enjoy your weekend, guys. Bye.